The leader of this panel is going to be Jisoo Yu, and she is a research assistant at Harvard with Professor Latanya Sweeney's data privacy lab, and we are so honored to have her here. She is going to begin to, as you know, every year Latanya comes herself, and she'll be here tomorrow, but this is part of her team, and by extension, to help expand the data map. And I think everybody already knows we don't have a data map, and the need to build one out is critical. And so let's please welcome Jisoo Yu, and she will introduce the wonderful panelists who also contributed to the data map. And so thank you.
Yeah, hi everyone. Like Deb said, my name is Jisoo. These are my students. I teach with Latanya Sweeney at Harvard. Two different courses. So two of the students are from a freshman seminar called Technology Science to Save the World. And one of the students was in a government class, and the name of the class was The Politics of Personal Data. So as you can see, they are both coming from a different perspective on how they look at patient records, right? One from a government lens and another one from a technology lens. But we still had them both work on re-identification cases because it's exciting, it's different, and it shows them a lot of the real world impact of looking at databases that are widely shared and widely distributed. So they are going to come up and talk about the methodology that we used for these re-identifications a little bit after, and they'll introduce themselves as well. And I am going to just talk to you very broadly about why we're doing this, what's the point, right? It's just Latanya and her team. It's a niche group. Who's going to be affected, right? Who's going to actually look at these very, very fine-grained data line entries that some random electronic medical health record inputted and distributed out, right? So really quickly, let me tell you a story. It's a true story, but I'm going to use an alias because as we're trying to protect patients from their information being distributed everywhere. But Steve Hannigan, he was in a car crash, and his condition, his diagnoses, formal and very accurate medical information was inputted into an electronic medical record. Now, he expects that his information will go to his doctor, that it will go to his hospital. It will also go to his insurance claims, etc. But you know, he does not expect that his data will go to everybody else, including sometimes your employer, your life insurance company. And he does not expect that his information will go from him to the hospital to becoming discharge data, de-identified, of course, but that people will purchase this data. And these people include large insurance companies. Now, these are the flows of information that are covered by HIPAA, the ones that are in straight lines. But of course, HIPAA being the Health Information Portability and Accountability Act. And that means that, you know, these are covered entities, and the United States has said that HIPAA governs the privacy of personal health information in this sense. It dictates who can get this information, but HIPAA covers less than half of this data sharing that we're looking at. And this information was revealed to us through data breaches that we went through. And this is the very essence of the data map. But what we're looking at now is, okay, so what about these discharge data? Right? So we look very specifically at the discharge data, and what we get, if my pointer will go, is some of the statutes, right? So this is an example of Vermont's statute of the mandate to share discharge data. So Steve is in this data. He doesn't know it. he might know that something about him is floating around in the air, right? But states are really, how shall I say, concerned and want to really favorably release this data so that research, innovation, and possibly good healthcare reform will come out of the data analysis, right? And what happens is that Vermont has been sharing this data since the 1980s, right? And this is just an example. There are 33 other states that share and sell information as hospital discharge data. But let's look at the very specifics of Vermont. There is case-specific diagnostic data, socio-demographic data, the medical reason for admission, treatment and services, duration and status of the patient, stay, not in years, but in specific days, and information about services, right? And this all has to do with specific diagnostic codes. So then, what is the nature of this? We have age groups, we have zip code, we have the gender, hospital service area, and different. Oh, okay. Sorry, I'll stay on the mic. Different information about the discharge of that particular patient. Now, seems my slides are out of order. Now, these are the people who are going to be able to purchase the data. The states also share who are the major people who purchase this. And we've compiled a list of some of the major purchases of different states. Now, I'm wondering, what are they doing with this de-identified data, right? They're healthcare companies, it makes sense, they run data analytics. But another thing that happens is that it's not very clear who is participating in these data sharing agreements and who is standing to benefit from these agreements and who is standing to be harmed from these agreements. So there's another story that I want to share with you of a woman whose alias is Amy Sanders. Now, Amy, she is from out of state. She also went to Vermont and she got in a car accident. She was one of the only few pedestrians who was hit by another car in this entire database. We were able to find her, and my students will go over the methodology, but we were able to find her and we were able to see that not only was she in a car accident, but she also had several different drug overdose instances, that she had cocaine dependencies, that she had different psychological issues. And this is the specificity of the data. I don't know if a lot of you are familiar with ICD-9 codes, but they're very specific. So we also understand that there are marital problems that are reported in discharge data. And all of this information is divulged to us by re-identification processes. Of course, we wouldn't know this data if hospital discharge data didn't include all these previous diagnoses, right? So we don't just learn about the specific instance that a person went into the hospital for. We learn about their entire health history that is more or less very, very private information. There's also a story that I want to share with you of a college student who was in an accident as well. And she was also a pedestrian, and she was hit by a car. And she had a broken leg, and as the ICD-9 code suggests, she's the pedestrian in the motor vehicle accident. We also learned that she has anxiety, she has depression. Now, she's a college student, and this information is not something you want around when you're a newly minted undergrad, right? So these are real people with real consequences for what if their information does get out, this aggregated information. Now, HIPAA provides very limited protection for them. And even though HIPAA provides limited information and we can, trash talk on how bad HIPAA is or how, maybe we still believe that it is a good enough measure for protecting patients, HIPAA standards are not used when state health databases are shared or disclosed, sadly. As I mentioned before, 33 states sell or share personal health data, but only 3 use HIPAA standards. And when we did a survey of what types of fields were disclosed, we were able to see, the level of HIPAA compliance. It's very strict when it comes to demographic fields. And this might come from a belief that, if we suppress all the demographics, no one will be able to find them, right? If we use k-anonymity to generalize, the 5 patients that have very unique records in our database, we won't be able to find them because demographics are all that matter. But that's not true, as we will show. And we also have this belief that, we can let admission and discharge fields be as specific as ICD-9 codes because no one will use them to find anybody in the database, right? Because we don't think that those fields can be used to find people in this data. Now, in the winter of 2015, Professor Latanya Sweeney did a re-identification of Washington State's healthcare database. And what she found was that 43% of news stories that she went through, these news stories reveal information about local car crashes, local accidents, etc. She was able to find 43% of those news stories corresponded uniquely to people in the Washington State database. And this is the method that she used, basically taking the public records, which is like, there's information online about your zip code and address. And then she was able to match it with your age, residence, and name that appeared in news stories. And the news stories would then reveal more information about this particular person, such as their gender, hospital that they were admitted to, and admission month. Now you take that aggregated data set that we just constructed, and then you use it to find the people in the hospital data. We're gonna use a similar methodology when my students talk about specifics of Maine and Vermont. We didn't use public records in Maine and Vermont, and we still were able to find them. In any case, news stories have information that others know, right? But in this way, we're able to tie it to a very official health record. Now, we had really good response in Washington. After we published, or after Latanya published, there were 2 states that responded very favorably, and they changed the way that they released the information. So, we have those check marks, and we're like, yes, we're making change. And the point of these re-identifications is not to say, okay, here's pointing a finger, shame on you, because we were able to find them. But it's more about, we're exposing just the existence of a vulnerability in hopes that improved methods will arise out of this, right? And we're not here to say, oh, you should have this particular method or this method. It's more about, here is the existence of a vulnerability. And now we're going to go into the specifics of how we went through this data. And they are Harvard students. They're fantastic, accomplished people. And it's really great to have had the privilege to work with them and also to get them interested in a particular field of understanding patients and their privacy, as well as how they're interacting with government systems. And they individually also have some interest in medicine. Alexandra, who is going to talk about Vermont, is a government major, and she is also a pre-med. So, she has a lot at stake in terms of understanding what is important when she interacts with her patients. And then our 2 freshmen are thinking of, Becina is thinking of concentrating in history of science with a minor in computer science. So we have people who are computer people thinking about the ethics and the privacy aspect, which is exciting, right? This is the progeny of this community. And then Harshita is also thinking computer science, I think, but she has a lot of talent. So she's like also thinking, what were you thinking?
Social studies or computer science, yeah.
Yeah, social studies as well. So we have people who are very interdisciplinary minded, and they understand that this takes a component of technology and also takes a component of what is already existing and how technology is influencing the ways that we look at electronic health systems and data sharing paradigms. So with that, Ali, do you want to come up?
Hi, so as Jisoo mentioned, I'm Thaler, and I'm going to talk about the methods and results that we obtained from Vermont. So here is just a few screenshots of the data that we found on Vermont's website called healthvermont.gov. As you can see, there are many, many data fields, and we extracted data that matched 8 of these, but this is to show that there's a huge wealth that's being recorded that we didn't even need to use in order to match various patients. So how did we go about this in Vermont? We first obtained articles using LexisNexis, primarily from the Keene Sentinel from New Hampshire, but with Vermont references, and the Brattleboro Reformer. And both of these newspapers included people that went to hospitals located in Vermont. So in order to find articles that would be relevant to our study, we used different keywords like hospitalized, transported, injured, hospital, and medical, and obtained the 8 data fields that you can see to the right. And by using these data fields, we were able to extract information that would be able to connect us with a patient record. Next, so out of the 69 total articles after our search, 14 of those articles mentioned patients that went to Vermont hospitals. Some of those patients that were involved in accidents went to a hospital on the border in New Hampshire, but that wasn't relevant to our data set, so we ignored those. That's where the others besides those 14 articles went. And out of the articles, we extracted different parts that would be necessary for cross-referencing. Those included the hospital code, for instance, Brattleboro Memorial Hospital, the sex of the patient, age, zip code, and date admitted, and then those translated into codes. This next slide shows exactly how that information was pulled out of the article. So as you can see in red, the Brattleboro Memorial Hospital is coded as 15 in the data set, and continuing on, the age is also coded. The age has a range, but it's still specific enough to be easily used in identifying patients. Again, same thing with the zip code. It's also in a range, but that didn't stop us from re-identifying either. The sex, 1 for male, 2 for female, and as you can see, the newspaper article describes facial injuries, and we found in the unique match that is shown to the right, the closed fracture of orbital floor is exactly describing the facial injuries. Just to further confirm, the E code, which is also an ICD-9 code, also matches the other motor vehicle traffic incident involving a collision. Again, corroborates that this is indeed a match. So initially we filtered using Excel just as our preliminary result, or to get preliminary results. After using the fields that I mentioned previously, we distinguished between similar matches with the diagnosis and emergency codes. And then we saw that not only could we re-identify, but we could also include additional diagnoses that were often unrelated. So it goes beyond a simple match. We could find more, as Jisoo mentioned a little bit. But anyway, so our initial preliminary result was 42.9% of the newspaper articles could be successfully matched to patient records. And this is using only Excel. So with that, we decided to expand, and now we included 201 articles. They were again categorized, and this time we automated it using Python so that we could cover more ground quickly. So the first one, this is also an alias, John Richards, and this slide is, I guess, most startling to me. The man from the article on the left side of the screen, you can see what we learned from the article is that he's 49 years old, a resident of Lebanon, New Hampshire, was taken to a Vermont hospital, however, so he's out of state. He was involved in a motor vehicle accident on a highway and sustained facial injuries. That's all we know about John Richards. After we cross-referenced and re-identified him successfully, now we know that not only did he sustain facial injuries, but he is a diabetic, he's morbidly obese, and he has hyperlipidemia, which is a disease with an abnormally high concentration of fat in his blood. So that shows beyond simply matching him to a record that he has very serious pre-existing conditions that could be used to discriminate against him, and you would never know any of this information about John Richards had he not had the misfortune of being in a motor vehicle accident. So that, to me, is the most astounding part of the re-identification. Overall, just to give you a quantitative summary, we had 270 articles returned in our LexisNexis search. 46 described patients taken to Vermont hospitals. 32 returned results in the cross-reference process, which means that they included all of the fields that we needed. 12 out of those 32 could be matched to one unique name, 30%, and 19 were successfully matched with a bin size or 1 or 2. So that was a very large percentage of matching. So just where has this gone since the 2011 data that we have used in this project? The ICD-9 codes are now updated to be ICD-10 codes, and those include, for example, this is one of the additions, a large degree of specificity in unemployment status, including change of job, or these are listed as diagnoses that you would find even if you got in a car accident. Change of job is a diagnosis, threat of job loss, stressful work schedule, discourse with boss and workmates, uncongenial work environment, other physical and mental strains relating to work, and sexual harassment on the job. So those are unemployment status diagnoses that really are completely unrelated to if you broke your arm in a car accident. All of a sudden, just because you happen to get in a car accident, maybe on a rainy day or something, all of a sudden now the public can know that you have an uncongenial work environment or are being threatened with job loss. So maybe were you distracted when you were driving your car? I don't know, there's lots of room for speculation. So that's just one example of how specific these codes are getting and the definite vulnerability in the way that data is publicly available.
Ali, really quickly, can you talk about what a bin size is?
Oh,
so
yeah.
you talked about 1 or 2 bin
Yeah.
sizes. If you want to just explain that a little
Yeah.
bit.
So the bin size means that when they were cross-referenced, if we weren't sure if there were 1 or 2 matches, so all of the fields matched and we got 2 returns on that, then we would say, okay, well, it's a match to 1 or 2. So it wasn't a unique match, but it was still between 1 or 2, if that clears that up.
Hi, I'm Becina Ganther. I'm a student at Harvard.
My name's Harshita Gupta, and I'm also a student at Harvard. Cool. So we're going to talk about the data that we re-identified for Maine. Yes, we had Maine inpatient records from 2010, which list admits to the hospital with all of the information that Ali described previously. We'll show you the database details, specifics in a bit So
So we use Nexus. We use LexisNexis, the database, to search through newspaper articles, and we found that most of our articles came from Portland Press Herald, Bangor Daily News, and Portsmouth Herald. We found 270 unique articles that involved patients being sent to a hospital in Maine.
you can see what the inpatient record for Maine looks like in these fields. Just to point some of them out, you have race and ethnicity, you have the typical demographic codes, but you also have things like the revenue codes, which list specifically what the insurance was charged for. You have up to 10 diagnoses, and these include pre-existing diagnoses, which are entered in for all patients irrespective of what they come in for. You see a bunch of this information that once we just match on simple fields, like we'll show you, we matched for patient sex and a bunch of demographic information, but we were able to find all of this rest out. Maine is not HIPAA compliant, unlike Vermont, so the data has very specific information on the geographic area. There's geocode is one of the fields listed in the inpatient records, and that lists a very specific town and area. It's very easy to find the key and legend for what geocode corresponds to what area, and these are publicly available. So this is kind of the data that we were working with and matching to the newspaper articles.
So here's just another example of collecting data from an article. So this is an article we found about a man whose car collided with a moose, and they were sent to the hospital. And so you can just see we basically just pull out basic information from the article and match it to the different data fields that we were going to search for. So once we found the different data fields, we then basically converted it into inpatient data. So if you see the data publication, the article was published in September 2010, so that matches to Q3. So all of the inpatient data, the year, because it's not HIPAA compliant, it's based off of the quarter for the year, so Q1, 2, 3, or 4, based off of the time it is in the year, patient's age, patient sex, the geocode, which was actually one of the most important parts of it, was being able to find the geocode, because some of these people came from really small towns where there weren't that many, like it wasn't that hard to pinpoint it because the town was so small and there weren't so many people living in each town. And then hospital codes, so where they were sent to hospitals, especially for smaller hospitals. Oh, okay. Oh, so the inpatient data, it's free and available online. So we found it for,
So this is from 2010, so it is no longer available. And Maine has updated the level of application and how they release the data. So for Maine now, you have to, have a data use agreement, et cetera. It's 2017 now, but this is 2010 data, but the fields are still very similar.
For Vermont data, it's readily available to download online. The 2011 data all through 2016, I believe, is accessible on healthvermont.gov. Anyone open to the public can download the data set.
The question was, is there a Maine statute that required the disclosure of the geocode in 2010? Required the disclosure?
We don't know the specifics of whether the geocode was required to be disclosed. We just...
Oh, no.
Well, the way that we talk about HIPAA compliance is when you are sharing data and you de-identify the data according to Safe Harbor Agreement, you should take out anything that's smaller than a zip code, depending on the population density of that geographic area. But what happens with Maine is that it's smaller than a zip code. So that's why we say it's not HIPAA compliant. I wouldn't be able to tell you that. Oh, the question was whether there was a main statute that required the hospitals to release the geocode in addition inside the database, or whether the main hospitals themselves decided this. We wouldn't be able to tell you. We're not lawyers, so we didn't look at, the hospitals didn't want to release it, but they were mandated to, right? We just know what we have, and we say, okay, this is what we have, then this is what we work with, right?
So the data that we have here is what we use to run through our Python program and find matches. And then once we had matches, like Ali said, 2 or 3 matches might come up for a single newspaper article. And then we use the ICD-9 codes, which list specific diagnoses to figure out what is an exact match. So if the newspaper article described a head injury, we would look at the 3 matches that came up for the given demographic information, and then use the diagnosis as a confirmation for which match is the one that lines up with the newspaper article. This is kind of different than Ali's approach because we just use demographic information. We aren't matching to begin with on diagnoses. It kind of shows what the non-HIPAA compliance does for us, the fact that Maine's demographic information in the inpatient data is pretty specific and allows us to, in a lot of cases, led to a unique match almost immediately, and then we were able to find diagnoses from it. So
in this example of David Jameson, we were able to find that they were patient ID 954. These are not the actual numbers, like accurate numbers. And through that, once you find the patient ID, you're then able to find other records for this person that were not going to be that would not have been available had they not had the newspaper article written about them. So we were able to find that David Jameson had depression, PTSD symptoms, and burn tissue, all just from the newspaper article, which, of course, these symptoms have nothing to do with the car crash that David Jameson was in.
Yeah, this is just a comparison of what came from the article and what came from the data after we re-identified it. This is another example of a Jane Doe alias, of course, and this stood out because she was mauled and dragged by a bulldog, and there was a lot of press coverage on this. There was a lot of community organizing around supporting her. She had pretty serious head and arm injuries. So a lot of media coverage, and because it's such a unique injury and it's a dog bite, the ICD-9 code was very straightforward. There's a code for a dog bite. We have it listed up there. There was a single match, and we were able to find pre-existing conditions of tobacco use disorder, asthma, meningitis, and a lot of press coverage around this. So it's one of the most easily identifiable records in the database and tells us a lot about the patient. And here you see, this is all of the information we were able to find about this patient. This is the entire inpatient record with some of the codes swapped out for their word descriptions. But you can see all of the insurance charges are here. You can see pre-existing diagnoses, and the dog bite one shows up here. And then the wound to the elbow, tobacco use disorder, asthma, etc. And yes, you can see the hospital code. So this is part of what we used for the original match, hospital service area of the patient, and then the geo code as well, which matched the area listed in the article.
So here the final results are: we found about 1,112 articles were returned from the LexisNexis database, and of those we were able to find 270 unique articles about patients taken to Maine hospitals. When we went through and used Python to match it to inpatient data, we found 132 that had matches, and of those 132, 53 of them could be matched to a specific name. So that's about 40%, which is quite a lot.
And just for clarification purposes, we didn't look for articles that gave us all of the fields we needed. We took the ones it was able to give us, and then we matched based on those. So not all of the 8 fields were necessarily met, but we were still able to find matches with, like, say 5 of those 8 met. So, yep, this is just a summary of our work, and we will turn it back over to Jisoo to wrap up.
So thank you guys for discussing some of the specifics. As you can tell, like this was a work that was done in a class, but it really means something when you take sometimes disillusioned students who are like, oh, this is all theoretical government work, or this is all, mathematics that I'm never going to use. And they actually apply their skills into a real world issue, and the light kind of like shines in their eyes because they understand, right? This is something that could impact me if I have different information in hospital data set. And we didn't even think about, the crossover between these two states, right? If I'm able to find somebody in one state database and can find them in another one, because like Ali talked about, a lot of the people who are going to Vermont hospitals, we could also find them in New Hampshire hospitals because they share such a large border. So there's a lot of ways that people can kind of disentangle a lot of the details. And we didn't even begin to cover all the different examples that we saw, not only with marital condition and mental health problems, we also saw birth data, right? There were defects. There was information about any complications during the pregnancy. So I don't know about you, and I don't think this is speculation, because I have heard of many stories in this auditorium about people being blamed by their employers or being single-handedly pointed out because their children have birth issues or they had a complicated pregnancy, right? So there are ways that, if I was an employer, I don't know if this happens, but I know of very specific incidences where employers will be able to find out who had raised the rates for everybody else in a small company. So there are very financial, emotional, and a lot of consequences that can arise if these methods are used not in order to make healthcare available for more people or for health outcomes to improve. Now, the next step is to expand this study to other states. And our goal is not to say, okay, stop sharing this hospital discharge data. And our goal is not to say everyone should be HIPAA compliant, because HIPAA has its own issues. But we're here to say, okay, we need to examine what are the better ways that we can start sharing this data so that there's a lot more utility and a lot of more preservation of privacy, right? So we have 29 states to go out of the 33, and we're hoping that we'll get favorable responses to understand that there are some real world vulnerabilities here. Like I said, we're not asking specifics, right? Because we know that HIPAA, it's not enough. And in our upcoming publication with me and Professor Latanya Sweeney, we're looking at data about specific individuals that has been redacted beyond HIPAA. We're talking about dates being reported as decade groups. We're talking about suppression of different fields, and we still have 20% re-identification rates. So again, the answer is not more suppression or more generalizability or more sophisticated statistic methods. It's about considering what is out there and what vulnerabilities will exist through experiments like these. So thank you all so much for listening. And I think we have time for a few questions. I'm not sure how long, but okay, great.
I just have one question. You mentioned that you're going to be doing studies at some of the other states. You already have results from 4 states. Why can't you just go to those other states and say, hey, these are the results of the studies we have done, so therefore you might want to look into your practices?
I wish, right? But what ends up happening is what we saw with Washington. So, brand name Professor Latanya Sweeney pushes out this publication and says, there is a problem that you might want to look into, right? And even then, people say, oh, no, we aggregated our zip codes in this way. and we changed the demographics in this way, or we changed changed the way that we report. Now we have data use agreements. Now we have, very specific requirements about who can get it. So they have these ways of saying we're not part of Washington. Our data is not the same as Maine. We're not a small town state like Vermont. So that doesn't apply to us. And you can see there's a lot of incentive to not want to change a lot of the things because either you don't perceive it as a threat, or maybe there are other ways that you think fixing the problem will work. So I can't speak to why they haven't changed it. I can just say that they haven't changed it.
Was this study presented to an institutional review board, and if so, how did the board respond? Was this study or series of studies presented to an institutional review board, and how did the board respond if it was?
Right, so the question is about whether the study was submitted to an IRB review board. And the answer is Maine and Vermont studies that we presented to you, they are under review. They are under review under a journal, but it's not specifically submitted to IRBs. So yeah, we're not specifically submitting it to Harvard's IRB. We're just submitting it to a publication.
When health information exchanges began, I had very big concerns about just exactly what's happening. And it's even worse because if any of you have read Adam Tanner's book, big businesses will be taking this information and building even bigger databases about all our health information that they have and can't sell. Adam did not mention, he didn't find any examples of where it's being sold, but I have an example of where it's being sold. So I have been against it from the beginning, and I've always thought health information exchanges, if put up by states, should be like telephone books. If you want your name in the telephone book, it can be in the telephone book. Then where you've received care so that your data can then be requested from that doctor or that hospital or whatever, can be delivered if you've asked for it. But otherwise, I don't think any of these places, including the federal government, which is doing it, should be collecting these kind of databases in the first place. It's a huge privacy violation, and they keep saying they're going to have great conclusions about it. It's going to make our health better, so it's a greater good. But frankly, from time immemorial, you're supposed to be able to go see your doctor and have that information kept quiet. And the government is actually promoting and making this worse. Thank you.
Looked it up. The Maine statute does require the disclosure of those geocodes. So might one possible solution to this be, and let me back up, the HIPAA privacy rule is obviously a federal floor of health information confidentiality. Get closer to the microphone, please. All right. So I'll just shorten my question. My question is, if state law requires a covered entity to do something, that is allowed under the HIPAA privacy rule at 164.512a. So might one solution, if you're having disclosure of identifiers that can allow the re-identification of the patients, to go to your state legislature and say, you may not have known this, but by requiring the disclosure of this patient data, it allows re-identification. So what we need to do is shrink or curtail or kind of shrunk down the state law, because once something is no longer allowed by state law, then it becomes now again prohibited under HIPAA at 164.512a.
I'm not sure what the question was. Oh, yeah. Okay. So I don't think I caught the specific number of legislation that you're talking about, but basically you're saying that if patients rally and talk to their legislature about these geocodes being the most identifying factor, then maybe we can kind of overrule the disclosure of the geocode specifically? Is that what you're saying?
So there's an exception in HIPAA that basically says if some other law requires a disclosure by a hospital, say, to, say, a state public entity, that the hospital can do it and it's not a violation of HIPAA, which is why I asked about why are you saying this is not HIPAA compliant. And I looked it up, and Maine actually has a regulatory provision, which would be another provision of law allowing the disclosure, not allowing, requiring the disclosure of all these identifiers, including the geocodes. So my thought is maybe one thing that we can do is go to Maine and Vermont, if this is the goal you want to achieve, and it might not be, and have them shrink down the number of identifiers they are requiring to be disclosed, right? Because under HIPAA, this is all allowed under 164.512A now. Right, to say it's not HIPAA compliant, that's not actually accurate. What we need to do is fix the state law that you normatively or substantively disagree with. I don't know if that makes sense, but.
Right. So yes, the geocodes were important, but it wasn't just the geocode, right? So there were all these other demographic factors. And so we're not here to say, okay, this specific field needs to be suppressed or anything like that, because we have no evidence that that will be the most efficient method. So yeah, like I said, we're just here to say that this is one way the problem exists. There may be plenty of other ways to do re-identifications that we haven't explored, because as you saw, there are so many fields. That might be up to somebody else if they want to do that. But yeah, we're just here to say, okay, here's one way that it was there.
No, I think this is fantastic work, and all I'm trying to say is that I think the states don't realize that with their mandatory disclosure laws, they are opening this up under HIPAA and allowing the amazing work that you are doing. Like I'm laughing because I'm from the border of Vermont, New Hampshire, so when you say, oh, the hospital on the border of Vermont, New Hampshire, you're talking about Dartmouth, Hitchcock,
Yeah.
right? And then all my relatives have gotten into motorcycle accidents, so I actually thought that was my cousin up there. I mean, this is amazing work, but at the end of the day, legally, it's Maine and Vermont's fault if we want to blame someone. So the question is whether we need to fix that or not.
Thank you.
Hi. So, first off, it's absolutely amazing work you're doing, and thank you for doing it. It really drives home an important point. In reaction to, I guess it was a couple of questions ago, have you brought this up with, you showed a lot of stuff in the 4 states, have you brought it up with the other states? Have you thought about any approaches to sort of crowdsourcing or distributing what you're doing, where you can get people, get some volunteers in some other states who are animated and moved by what you're doing to try to do a little bit of work in their state to show one re-identification that shouldn't be able to happen, or push back against the arguments the states are making back to you when they say, oh, we're not like Vermont, we're not like this state, we're not like that state, here's why we're different. If you can get some volunteers in other states to help you, I think you could show them. I don't know if you thought about that. Or is it possible, I should ask, as a question.
Yeah, so we are not like one of those nonprofit organizations that has like that crowdsourcing power. Okay. We are just very humble research assistants and students. So yeah, we try to tackle one thing at a time. Okay. But I mean, I think somebody else could do it. As you can tell, our methods are not complicated. But yeah, we're not advocating for anything. I don't think we have enough knowledge, as she demonstrated, about the laws and specifics about how this could play out. We just are here to do a good job on the work that we are able to do.
You're doing an amazing job. I think everyone in this room agrees.
Thank you.
Hello, Jisoo.
Hi.
Thanks to you and your team. And in summary, I just want to kind of state the obvious, make sure I get the message right. And that is, you're taking health information that's anonymized basically from the public domain, or at least it's easily accessible through relatively informal methods to collect it. You're then taking public information in the form of newspapers, articles, and just correlating those two together to reveal that anonymized data can in fact be de-anonymized and reveal big vulnerabilities about human beings and the potential impact to their lives, and you've done that at a scale of a few hundred. Is that a fair assessment of the work? So the obvious question on a conference that includes the ethics of using machine learning, I always think of how do you scale things out, and you start to ask yourself, well, could we use public records like property records? Could we use social media records? Could we use just your Facebook profile? Could you use a whole series of public information, use machine learning to then correlate that against the public medical records that are anonymous and really scale this out to reveal, you know, a much grander vulnerability than just say 40% of 200 records? And you have a suspicious look on your face. I'm going to give that back to you.
Thank you. So you're asking, if I got it right, whether machine learning could be used to like scale this up. So our version of scaling up was going from just visually inspecting these records and these newspaper articles and using then a Python program that was maybe a few lines long. I think you and I and most people here know that the answer is yes. There's a lot of room for algorithms to take what we've done and take it up to scale. But this is what we've been able to do. So if you can imagine somebody who has a lot more resources, maybe, you know, it is possible. I don't think I can say what the identification re-ID rates would be for that. Yeah, I just know that what we found was 40%.
It just seems like it could really, if you had intentions, if I were insured and my intentions were toward predicting future health and maximizing my financial position, that if I really wanted to, I could scale this up with relatively easy technology, or well, I shouldn't say easy, well understood technology.
So you're saying that if you had, you know, relatively well understood technology, you would be able to, machine learning, you would be able to rev up everything that we've done. I have no doubt in your abilities to do that. But as I said, I don't think I can predict that number for you. I can't predict, you know, given X amount of resources and this amount of expertise, you're going to be able to get this much more. Yeah, this is just.
My motivation would be to be able to demonstrate, to extend your work, to have it be more impactful, to make greater change, because it'd be revealing a far greater problem than just a couple of hundred records, right? And it would be, if you did this at some scale, and obviously you would want to keep your results anonymous, but you could statistically share it, it could have a really big impact. Far greater than just a couple. That's my only tip.
Thank you.
Okay.
Fabulous. Aren't they wonderful? And yes, Kurt, if you know anyone that has some of those resources, I know the Data Privacy Lab would be glad to do that. We'd love to. That's been a major problem. Where's the resources to scale this up? But I think this was such a terrific panel because we've got young, brilliant people beginning to work on this issue and seeing how important it is. And it's I don't know if it's a coincidence that you're all women, but it's a lovely coincidence. So thank you so much. And they're going to be around tonight too at the gala. So hopefully everyone can talk with them. And anyway, thank you again.